covered the type 1 and type 2 hypersensitivity reactions. Let's move on to type 3. In type 3, immune complexes, that is, antigen-antibody complexes, are transported by blood and then they are deposited on abnormal sites. Means that these are the complexes that are not phagocytized by reticuloendothelial system. They may travel by the blood, they are soluble in the blood, and they get into specific sites. Now, accumulation of complexes is associated with abnormal activation of complements, and that's where the pathogenesis begins. Chemotaxis of macrophages and PMNs as a result of activation of complements is associated with phagocytosis of debris of host cells and release of damaging lytic enzymes in different tissues. The net result is damage to healthy tissues. Since the complexes are traveling via blood, the most common site of injury in type 3 is the endothelial lining of the vessels, locking this information. However, if I want to name the top 3 most common sites for type 3 effects, I'm going to name for you the blood vessels, the renal glomeruli, and synovial joints. You want to add a number 4, you can add skin to your list. Therefore, the 4 must-know clinical findings in type 3 are going to be nephritis, vasculitis, arthritis, and dermatitis. In order to understand better the pathogenesis of the type 3, let us look at this diagram. This diagram illustrates pathogenesis of type 3 hypersensitivity. Circulating immune complexes deposit on tissue cells or on the target cells. And when they get deposited in there, they attract polymorphonuclear cells and macrophages. And these cells can bind via their Fc receptors and may directly phagocytize some of the complexes. The complexes can now activate the classic complement system. The C3b complement fragments, as we have discussed before, has very strong opsonizing effects, and they attract more macrophages and more PMNs to the site of complement activation. Upon contact, these cells release their lytic enzymes on the tissue cells. Meanwhile, the C3b complement fragments activate complements 5, 6, 7, 8, and 9, the so-called MAC complex. Activation of the MAC complex causes release of perforins, and these perforins will permeate and lyse the target tissues. I want you to note that in this diagram, the candy sticks next to C3b illustrate the concept that this complement fragment coats the tissues and cells and makes them attractive to the phagocytic cells. Let's talk a little about immune complexes. We already said that these are involved in the pathogenesis of the type 3 hypersensitivity reactions. Immune complexes are soluble units of antigen-antibody. So they act as a soluble unit as a whole. The antibodies are usually IgG, but they may also be IgM. And in this diagram, I'm showing the IgG units, so I put them in a circle for you so that you know that as a whole, they act as an antigen. So this time, the complexes as a whole, by this I mean the IgG or IgM plus the antigen, together they act as a complex, if you wish, antigen. Under normal situations, these complexes are cleared by the body by the innate cells in the spleen or in the liver. However, If these complexes are not cleared, the entire unit, that is, the antibody plus the antigen, they act as an epitope and can deposit on the vessel walls, in the joints, and in the glomeruli. The units that have a stronger ability for fixing complements show a stronger tendencies to initiate type 3 hypersensitivity reactions. Like conventional antigens, these complexes can fix complements and they can induce opsonization and phagocytosis. Smaller units may have the tendency to go to areas adjacent to the vessels. So the larger units affect mainly the vessels. The smaller units may get into the glomeruli and may get into the tissues. In addition to attraction of the PMNs and macrophages by C3b, the complement fragments of C3a and C5a, the so-called anaphylotoxins, can also attract the mast cells to deposit sites, and these mast cells release histamine, which can cause urticaria. The most common deposit site of soluble complexes is in the wall of vessels, as we said before. Neutrophilic infiltration and eosinophilic deposition may result in fibrinoid necrosis, the so-called necrotizing vasculitis. Also note that damage to the vessel walls allows for leakage of amorphous fibrin into localized areas. This results in a pink appearance with hematoxylin and eosin staining, hence the term fibrinoid. And this is the reason for the origin of the term of fibrinoid necrosis. I want you to also note that necrotic debris are normally phagocytized. However, if they are not phagocytized, they tend to calcify over time. Now is a good time for us to cover the major diseases that result from type 3 hypersensitivity. The two classic ones are serum sickness and Arthus reaction, that they have a lot of similarity, and that's why I like to discuss them together for you. Let's first begin with the serum sickness. This condition is of historical value, as horse or animal blood are no longer transfused to patients. Note that in the past, horses were injected with pathogens to produce antibodies, for instance, antibodies against diphtheria, tetanus, or scarlet fever. But these days, we no longer practice this. The antigen that evokes immune complex formation is a wide range of foreign proteins. As you can tell, there are so many different proteins in the horse serum or blood that they are incompatible or they are foreign to the human recipients. Within 5 days after infusion, a wide spectrum of antibodies are produced in the recipients against these foreign proteins. This leads to antibody-antigen complex formation in the host or in the recipients. If you're interested to know what is the use of animals, such as rabbits or horses, in current medical practice, I want you to know that currently anti-thymocyte globulin, ATG, against human T cells that are derived from horse or rabbit are the main products used for prevention and treatment of acute organ rejection and therapy of aplastic anemia. So, what are the top two indications of anti-thymocyte globulin? Organ rejection and therapy of aplastic anemia. Also, I want you to know that currently the most common causes of serum sickness are medications that react with or modify serum peptides of the hosts. Examples are antitoxins, antivenoms, and hormones from other species. Streptokinase, polyclonal or monoclonal antibodies developed in animals. Example, as we said earlier, is anti-thymocyte globulin, and OKT3 that I'll be covering more in details later for you. So as you can tell, these days, the most common cause of serum sickness is interaction between drugs and peptides in the host cells. The classic finding in serum sickness is fever. However, symptoms in addition to fever include arthritis, vasculitis, and nephritis. The next type 3 hypersensitivity reaction is the Arthus reaction, which is a localized version of the serum sickness. This is the localized subtype of serum sickness, and unlike serum sickness, it only causes localized and cutaneous vasculitis. Currently, Arthus reactions are uncommon and infrequently seen after multiple vaccinations with products that include tetanus or diphtheria toxoids. Common findings of Arthus reaction are localized edema and necrosis of the affected areas. The next type 3 hypersensitivity disease that we have to discuss is rheumatoid arthritis. This condition is an immune-mediated inflammatory disease, IMID. Immune complexes that are composed mostly of IgM rheumatoid factor, or F factor, they attach to Fc portion of circulating IgGs. Rheumatoid factor less frequently may be composed of IgG or IgA. The hallmark feature of rheumatoid arthritis is persistent, symmetric polyarteritis or synovitis that affects the hands and feet. Let's go through the pathogenesis of rheumatoid arthritis. Joint damage begins in the synovium that nourishes the cartilage, that is avascular. But this synovium also produces hyaluronic acid, which is the lubricant of the joint, collagens, and fibronectin. In normal individuals, the synovium is thin. In RA, synovium greatly hypertrophies and becomes infiltrated with fibroblasts and macrophages. The subintimal coating of the synovium, where the blood vessels are located, will now be infiltrated with innate and adaptive inflammatory cells, and most importantly, phagocytic cells, mast cells, mononuclear cells that may characteristically evolve into multinucleated osteoclasts in the synovium. The hypertrophied synovium is known as panos and will characteristically invade and destroy the adjoining cartilage and bone. So how would you treat rheumatoid arthritis? We can use non-steroidal anti-inflammatory drugs. We can use non-biologic and biologic disease-modifying anti-rheumatic drugs, DMARDs. We can use immunosuppressants and glucocorticosteroids. Early therapy with the DMARDs is now the standard of care and greatly reduces the progression of the rheumatoid arthritis. Let us quickly discuss the treatments for rheumatoid arthritis. Let us focus on disease-modifying anti-rheumatic drugs or DMARDs. The term DMARD applies to a group of drugs that, in contrast to anti-inflammatory medications such as glucocorticosteroids, they tend to slow down the disease process. Examples are abatacept. The brand name of it is Orencia. This is a T-cell co-stimulatory signal inhibitor, and as we have mentioned earlier, the well-known protein B7 is involved in interactions between T cells and APC cells, and it acts as a co-stimulatory factor, and Orencia inhibits that. A few other medications are adalimumab, the brand name of it is Humira, golimumab, brand name Simponi, and infliximab, brand name Remicade. These are all tumor necrosis factor inhibitors. And as you can tell, tumor necrosis factor also plays an important role in pathogenesis of rheumatoid arthritis. The other drug is D-penicillamine that reduces T cell numbers. Sulfasalazine and chloroquine, they suppress interleukin-1 and tumor necrosis factor alpha, and they induce apoptosis of the inflammatory cells. And these are also helpful in management of rheumatoid arthritis. The final two drugs are azathioprine and methotrexate. These are purine synthesis inhibitors. I want you to note that the term DMARD is also a misnomer, as these drugs also are used in Crohn's disease, systemic lupus management, Sjogren's disease management, and management of sarcoidosis. Pathogenesis of rheumatoid arthritis is commonly believed to be due to heavy involvement of the innate system. However, many of the DMARDs target the adaptive immune system, and they are shown to be effective in this regard. These findings suggest that pathogenesis of rheumatoid arthritis is multifactorial and must also involve the T cell contributions. And that's why a little earlier I said Orencia is helpful in managing rheumatoid arthritis. Let us turn our attention to systemic lupus erythematosus. SLE complexes are composed of several anti-nuclear antibodies, ANAs, that make complexes with antigens. Lab tests with indirect immunofluorescence have identified several subtypes of anti-nuclear antibodies, such as anti-double-stranded DNA antibodies, anti-Smith, anti-SM antibodies, antihistones, anti-SSA autoantibodies. SSA stands for anti-Sjogren syndrome related antigen A, that is also known as anti-Rho antibody. Anti-Smith antibodies are very specific marker for systemic lupus. Approximately 99% of individuals without SLE lack anti-Smith antibodies, but only 20% of people with SLE have these antibodies. Antihistones are much more common, however, with drug-induced systemic lupus. Systemic lupus is triggered by viruses, bacteria, and allergens, and can be aggravated by humoral factors such as estrogen, environmental stimulants such as ultraviolet light, or certain drugs. These stimuli begin a reaction that leads to destruction of bodily cells and exposure of their DNA, histones, and other nuclear proteins. Adherence of self-nuclear proteins to peptides of pathogens or drugs, the haptens of the drugs, activates the adaptive system and B lymphocyte cells, and as a result, B lymphocytic cells will produce antibodies against these nuclear-related proteins. These antibodies now clump into antibody protein complexes and adhere to endothelial surfaces. They damage blood vessels in critical areas of the body, such as renal glomeruli or the skin. Common findings in systemic lupus are butterfly facial rash, nephritis, arthritis, and vasculitis, the classic common findings with type 3 hypersensitivity diseases. Major causes of drug-induced lupus include procainamide, isoniazid, hydrolysine, quinidine, and phenytoin. Let's quickly review the drug-induced lupus. You may not have this segment in your immunology book because I have these slides and associated texts in your cardiovascular pharmacology chapter, and the texts are in the triology book, so you may refer to that chapter. This is the short list of medications that they cause drug-induced lupus. As I've also covered in cardiovascular system, lupus means wolf, and you're going to see this diagram on page 87 of your triology book. And I have 6 animals in here to somehow give you a good mnemonic. Canine reminds you of procainamide, so this is one of the drugs that causes drug-induced lupus. Hyena reminds you of hydrolysine, which is a vasodilator. Mink, it has a very nice fur, and that reminds you of Rogaine, and that reminds you of minoxidil, and of course it's going to be also minoxidil helpful for hair growth, supposedly. Python is for phenytoin, which is an anticonvulsant. In hibernation, INH is isoniazid, and panda and penguin will remind you of penicillamine. In the same chapter, I have compared and contrasted for you the classic lupus with drug-induced lupus erythematosus, which is DILE. Epidemiologically, systemic lupus is more common in Afro-Americans, and the female-to-male ratio is 9:1. Patients tend to be younger, like in 30s or mid-20s. However, DILE is more common with Caucasians. Female-to-male ratio is the same, and also it tends to happen in older individuals. When you look at the lab findings, antihistone antibodies are common in systemic lupus. Anti-double-stranded DNA is also common, and collectively you can call these two anti-nuclear antibodies, and over 95% of the patients tend to have these anti-nuclear antibodies, which collectively stands for antihistones and anti-double-stranded DNA antibodies. With regard to DILE, antihistones are by far more common. Anti-double-stranded DNA is less common, but again, 95% of these patients also present with anti-nuclear antibodies. Again, anti-nuclear antibodies is a generic term. It may stand for anti-double-stranded DNA or antihistone antibodies. With regard to cutaneous findings, SLE presents with more profound cutaneous findings. They have more discoid plaques. However, they have less perforations. With DILE, the cutaneous findings are less common. They have no discoid plaques. However, they have more perforations. This is, of course, a discoid rash, and as I said, this is more common with the classic systemic lupus. And of course, this is a real disc. And you're going to see perforations here, and you're going to see petechiae, and this is more common in DILE, drug-induced lupus. Let us continue our discussion of the type 3 hypersensitivity diseases with polyarteritis nodosa. PAN, or polyarteritis nodosa, is a systemic necrotizing vasculitis of small and medium-sized arteries. You're going to find more texts related to vasculitis in your bare minimum pathology book and also in pathology lectures. Just to make sure that you lock in this information, there is no strong association of polyarteritis nodosa with p-ANCA. p-ANCA stands for perinuclear pattern of anti-neutrophil cytoplasmic antibodies. There is no strong association. only one of the subtypes of polyarteritis nodosa may present with PANCA. About 30% of the patients with PAN have chronic hepatitis B and deposits containing hepatitis B surface antigen, hepatitis B surface antibody complexes in the affected vessels. Cytomegalovirus particles are also associated with PAN. I want you to note that only one type of PAN is associated with perinuclear pattern of anti-neutrophilic cytoplasmic antibodies. That particular version of the PAN affects mainly small arteries. Major lab findings of polyarteritis nodosa include elevated serum leukocytic number, elevated erythrocytic sedimentation rate, and elevated C-reactive protein. Treatment includes glucocorticosteroids, cyclophosphamide, rituximab, and infliximab. As we said earlier, infliximab is a tumor necrosis factor inhibitor. I want you to note that cyclophosphamide is not recommended in hepatitis B-related PAN, as it is shown that it enhances the viral replication in those patients. This brings us to post-streptococcal glomerulonephritis. Again, I've covered this in details for you in the renal pathology course and also in the bacteriology. But for now, let's quickly review the major associations of PSGN. In post-streptococcal glomerulonephritis, the immune complexes are composed of streptococcal cell wall antigens and antibodies against them. Major manifestations is acute nephritic syndrome, and patients present with oliguria, hematuria, and hypertension. This is the triad of nephritic syndrome. Glomerular biopsy and immunofluorescence staining reveals coarse deposits of complexes, the so-called lumpy, bumpy pattern. In renal pathology course, I've covered this in details for you. However, you may be interested to contrast the renal biopsy findings of PSGN, which is a type 3 hypersensitivity, with Goodpasture's syndrome, which is a type 2. And of course, both of these conditions, the common denominator of these conditions is that the renal glomeruli is going to get affected in both. However, in Goodpasture's, also the basement membrane of the lungs is also affected. In PSGN, the complexes are big and coarse, whereas in Goodpasture's, they are composed of antibodies and they are very fine. It is also important to compare and contrast rheumatic fever and PSGN because both of these conditions are a consequence of Streptococcus pyogenes infection. In rheumatic fever, which is a type 2 hypersensitivity, the antibodies that are generated against the streptococcal antigens cross-react with the cardiac myocytes. This is, as we said earlier, due to molecular mimicry, that the epitopes of the myocytes resemble the M protein of the Streptococcus pyogenes. In PSGN, certain streptococcal cell wall associated proteins are combined with antibodies to induce immune-mediated acute GN. Some experts believe that one of the cell wall proteins of streptococci, the so-called M12 protein, may have epitopic similarities to glomerular basement membrane. This may indicate that epitopic mimicry may also play a role in etiology of PSGN. Again, I'm drilling you. You may see this diagram in renal pathology book. Children may get impetigo or they may get strep throat. As a result of infection with Streptococcus pyogenes, we expect the strep antigens to be present in the blood of these patients. Our bodies produce antibodies against those antigens, and now antibody and antigens, they make complexes Normally, these complexes are phagocytized by reticuloendothelial cells. However, in some unlucky children, these complexes travel via blood and they get deposited into the glomeruli, as I have covered this in details for you in the renal pathology. Quite often they are deposited in subendothelial positions, but sometimes they may get deposited in subepithelial positions. And this is where they're going to activate the complements, and they cause damages, and they cause nephritic syndrome. And as you can recall, the triad of the nephritic syndrome, the mnemonic for it is H2O. Imagine that the number 2 is a superscript to remind you of hypertension. So the two H's stand for hypertension and hematuria, and O stands for oliguria. Again, you're going to see this diagram in your renal pathology. You may review that, but to give you a quick refresher here, what is the coarse, lumpy, bumpy immunofluorescence subepithelial deposits in PSGN? And this is how you're going to see the immunofluorescence findings. These are composed of IgG or complement 3. Is serum complement 3 decrease or increase in PSGN? It is decreased in PSGN because it's consumed in the nephrons. How is the prognosis of PSGN? The prognosis in these children is very good, and it is a self-limited condition. 95% of the patients are cured. What is the important lab finding in a patient suspected of nephritis due to a streptococcus infection? Identifying the anti-streptolysin O antibody in the blood of these children or the patients. This is diagnostic. Which of the two populations more often contracts PSGN, and in which one the symptoms are more severe, adult or children? Children get it more. Adults get it less, but they get the more severe version of the disease. Let us continue our discussion of major type 3 hypersensitivity diseases with farmer's lung. Farmer's lung is also known as hypersensitivity pneumonitis and extrinsic allergic alveolitis, and it is classified as a restrictive pulmonary condition. Antigens are thermophilic actinomycetes growing in moldy hay and crops. A notable actinomycete is Micropolyspora feini. The early symptoms of farmer's lung include dyspnea and fever. Later symptoms in chronic cases include anorexia and weight loss and may progress to pulmonary fibrosis. Lab findings include leukocytosis and diffuse interstitial and alveolar pulmonary infiltrates. Symptoms usually begin 4 to 6 hours after exposure to associated organic dusts. Symptoms of hypersensitivity pneumonitis support the role of type 3 immune complex hypersensitivity reactions, whereas the chronic manifestations resemble delayed type hypersensitivity, which is type 4 hypersensitivity. Structural lesions include granulomatous inflammation with multinucleated giant cells, and this condition affects terminal alveoli, and you can compare this with hypersensitivity type 1 condition. Let's look at the type 4 hypersensitivity reactions, also known as delayed type. This type is cell-mediated. In contrast to other hypersensitivities, it's not antibody-mediated. As such, it does not affect the target tissues via the blood. Immune cells include cytotoxic T lymphocytes, T helper 1 lymphocytes, and macrophages. Delayed type hypersensitivity takes longer time to get initiated, and you can compare it with the antibody mediated hypersensitivities, the other three kinds, that usually they take hours to days to manifest. Let's look at the immunopathology of the delayed type. Exposure to sensitizing antigens induce memory T lymphocytes. Sensitized T lymphocytes now release cytokines, including interferon gamma, after antigenic encounter. Interferon gamma activates macrophages and causes production of tumor necrosis factor. Examples of delayed type hypersensitivity include tuberculin test. With this test, the T cells that reside in the skin, they react against the tuberculin, which is more specifically derivative of the mycolic acid of the bacilli. The other example is allergic contact dermatitis. In this condition, the skin Langerhans cells react to the antigens. Type 1 diabetes mellitus. T cells react against islet cells, insulin, and glutamic acid decarboxylase. In multiple sclerosis, T cells react against myelin of CNS, and more specifically oligodendrites, and quite rarely against the Schwann cells. Guillain-Barré syndrome. T cells react against myelin of peripheral nervous system nerves. In Hashimoto thyroiditis, T cells react against thyroid antigens. In graft versus host disease, T cells of transplant origin become activated against major histocompatibility complexes of the host. In contact dermatitis, such as poison ivy, oak, heavy metals such as nickel, detergents, antiperspirants, and thimerosal that we use for contact lens. And finally, in rheumatoid arthritis, whereby the T cells react against synovial joint membrane and possibly type 2 collagen. Let's summarize and let's look more closely at the pathogenesis of type 4 hypersensitivity. I'm going to refer to this diagram for you. After initial exposure to the antigen presenting cells phagocytize the antigen and display its peptides on their MHC2 molecules. After they migrate to the local lymph nodes, they present processed antigen to naive CD4 positive T cells. This process requires CD86, CD28 matching and TCR MHC2 antigen connection together with the interleukin 12 that is produced by the APC cells. As a result, the naive T cells get activated and produce interleukin 2 and interferon gamma and differentiate into Th1 cells that are able to produce colonies of effector memory Th1 cells. These long-lived memory cells will be ready to quickly react upon re-exposure to their cognate antigens in the future or after subsequent exposure. So what will happen with subsequent exposure? When tissues are re-exposed to the same antigen, the APCs once again uptake the antigen, degrade it, and display it on their MHC2 proteins. However, this time, the circulating antigen-specific memory effector Th1 cells that have already propagated recognize the peptide MHC2 complex and pour interferon gamma onto macrophages and convert them onto voracious phagocytes. These phagocytes have the ability to mount a high amount of TNF-alpha and interleukin-1, which in turn promote intense inflammation of local tissues. The interferon gamma produced by the effector Th1 cells also induce formation of granulomas and giant cells. Celiac disease, gluten sensitivity, involves circulating autoantibodies against the gluten and small bowel villi, but the condition is classified as a type 4 hypersensitivity reaction. Why? Celiac disease is associated with anti-gliadin and anti-tissue transglutaminase antibodies and lymphocytic infiltration of the affected intestinal mucosa. Deaminated gliadin is locally phagocytized by the antigen-presenting cells, and its epitopes are presented on the MHC2 molecules, which results in T-cell activation. There is a strong association with the presence of HLA type 2, more specifically DQ2 and DQ8 alleles that can stimulate a T-cell response against tissue transglutaminase, TTG, in the extracellular matrix of intestinal cells and subsequent inflammation of the intestinal mucosa and eventually villus atrophy of the small intestine. Subsequent exposures to gluten expose the intestinal macrovilli to macrophages that are stimulated by interferon gamma. IgA antibody isotype is the predominant anti-gliadin and anti-tissue transglutaminase in serology of celiac disease. However, patients may also present with IgG isotypes. I want you to note that in patients with dermatitis herpetiformis that is closely associated with celiac disease, patients may express tissue transglutaminase IgA antibodies. In celiac disease, these antibodies are involved in destruction of the villus extracellular matrix, and killer cells target the destruction of intestinal villus epithelial cells. For this reason, the profound biopsy finding in patients with celiac disease is villus atrophy.